Our speakers for today are Prof. Melvyn Freeman. Prof. Melvyn Freeman is a consultant in public health, a psychologist, and therapist. Prof. Melvyn is currently a consultant on public mental health. He has been involved in policy and legislation, as well as health advocacy for over 35 years. He was the Director of Mental Health and Substance Abuse and later Chief Director for Non-Communicable Diseases at the National Department of Health and is an expert advisor to the World Health Organization. He has held research and consultancy positions and published extensively on health systems and services, mental health and HIV, youth mental health, and community care. He is Professor Extraordinaire at the University of Stellenbosch. Our second speaker for today is Ms. Jennifer Drummond, who is the HIV Prevention Branch Chief of CDC South Africa. Prior to joining CDC South Africa as an epidemiologist and branch chief of the HIV Prevention Branch, Jennifer worked to support PEPFAR countries through her epidemiologist positions on the Gender and Youth team in the HIV Prevention Branch and in the Office of the Director at the CDC Division of Global HIV and TB in Atlanta. Jennifer holds a Master of Public Health degree from Tulane School of Public Health and Tropical Medicine and a Bachelor of Science degree in Psychobiology from the University of Evansville. Jennifer is extremely passionate about gender-based violence prevention and response and mitigating its impact on health and the lives of South Africans.
So I am thrilled to be able to kick us off today on this discussion. And as was mentioned, my name is Jennifer Drummond. I'm currently the HIV Prevention Branch Chief in CDC South Africa. So I'll be taking us through just a brief introduction around HIV programs and prioritization of populations and mental health. So what we'll be looking at today, just giving a brief overview of our PEPFAR strategy. Talk a little bit about priority populations and key populations in both our PEPFAR strategy and guidance, as well as the South African National Strategic Plan. Then we'll go into a little bit about mental health in the SANSP, as well as in our PEPFAR strategy and guidance. And then we'll give an example of prioritization in PEPFAR programming. And then, of course, the all-important, where do we go from here? So at the International AIDS Society Conference last year, Ambassador John Nkenkesong revealed our exciting new 5-year PEPFAR strategy. The strategy is organized into 5 pillars, as well as 3 cross-cutting enablers. We're going to quickly review Pillar 1, Health Equity for Priority Populations, as that is the most relevant to our discussion. But before we get deeper into that, let's first take a look at equity and equality, and come to a common understanding of what we mean by health equity under this Pillar 1. So what you see here are 2 visuals. The one on the left is a representation of equality. The one on the right is illustrating equity. So for PEPFAR, health equity is the absence of unfair, avoidable, or remediable differences among groups of people, health systems, services, and policies. So why do we focus on health equity versus health equality? While equality is the state where all individuals can equally access the same health services, equity recognizes differences between individual circumstances and tailors services and advances policies to achieve optimal health outcomes for all. So when we think about the prioritization of populations under our PEPFAR strategic Pillar 1, we're driven by the understanding that pandemics or epidemics do not affect all people or all communities uniformly. For instance, we know that adolescent girls and young women, children, and key populations are disproportionately affected within the HIV epidemic. So if we can address and close the equity gaps that we see locally, we can have a much greater impact on new infections. Our PEPFAR strategic Pillar 1 has a further focus area specific to key populations. And in line with the entire 5x3 strategy, this focus area stresses the need to support leadership in this space by the community who is being served, so that the solutions truly address the existing inequities. The South Africa National Strategic Plan similarly puts a fine point on this topic of population prioritization by differentiating priority populations and key populations. Priority populations are defined as populations who are particularly vulnerable in certain contexts and may have reduced access to health and social services. And key populations are defined as groups who are at increased risk of HIV, irrespective of the epidemic and the local context. And PEPFAR definitions are fully in line with these classifications that we see here in the South Africa NSP. As both the PEPFAR South Africa country operations planning process and the South Africa NSP are data-driven in terms of priority population classification, we do see this full alignment here, or most alignment here, between the priority populations identified in the SA-NSP, as well as identified in our PEPFAR South Africa country operations plan for this current fiscal year. And here we again see the result of a data-driven classification of populations as key populations with a full alignment between the South Africa National Strategic Plan and our PEPFAR South Africa country operations plan for this fiscal year. So now as we move into the prioritization of HIV program focus areas, the SA National Strategic Plan presents a very strong data-driven case for prioritization of mental health in HIV programming, noting that mental health disorders are not only a risk factor for HIV, but are also a barrier to prevention intervention access for HIV-negative individuals and a barrier to treatment retention and viral load suppression for persons living with HIV. And when we look into our PEPFAR 5-year strategy, we see that mental health interventions are identified as a key component of patient-centered care. And we hear the call to efficiently integrate mental health services into our programming. So what does the priority population classification of people living with mental health issues mean moving forward? And what does the increased focus on mental health in our guidance documents and policies actually mean? So we'll take an example here. And this example is that of the classification of adolescent girls and young women as a priority population. So data from a number of countries, including South Africa, had shown a stubbornly disproportionate number of new infections in adolescent girls and young women, particularly in the 20 to 24-year-old age band. These data were a large part of the impetus for the creation of the DREAMS Global Partnership, which aimed to urgently reduce the number of new infections in AGYW. Once AGYW were identified as a priority population, the field was driven to conduct more research and collect more data to understand the social and structural drivers of the HIV epidemic in AGYW. And many of these studies identified GBV as a key vulnerability and as a key driver of the epidemic in this population. As such, the DREAMS package evolved to ensure that GBV prevention and response was a core component of the DREAMS package. So DREAMS is essentially the HIV programming result of a population being classified as a priority population and the concomitant prioritization of a cross-cutting issue. So where do we go from here when thinking about HIV programming and persons living with mental health conditions? I certainly cannot speculate if we will see any DREAMS type initiatives come through. But I can say that the data-driven classification of persons living with mental health conditions as a priority population catalyzed PEPFAR South Africa's increased integration of mental health considerations and interventions across its programming for this current fiscal year, which started on 1 October. We're following the PEPFAR mandated health equity approach, meaning that we aim to advance equity by moving toward eliminating rather than simply documenting inequities through prioritizing, meaningfully engaging with, and empowering populations who have had historical, contemporary, or cultural injustices. In an August 2023 article, our PEPFAR leadership reinforced the prioritization of mental health and put forward some ideas for next steps in our programs. In South African HIV and health programs, we have a number of best practices from which we can pull, and data and evidence on which to base program shifts and component integration. I'll highlight 2 examples. The first is training frontline clinical and lay health workers to provide first-line psychosocial support and service referrals to persons disclosing experience of violence. The second example is the Key Population Centers of Excellence initiative being driven by the Department of Health, which aims to reduce stigma and discrimination against key populations in public health facilities. Now, we've been speaking here primarily about mental health conditions such as depression or post-violence trauma, but we have not really dug into severe mental health conditions such as schizophrenia, bipolar disorder, or psychosis. Given the link between severe mental health conditions and HIV, I'm thrilled to turn over to the next presenter to take us forward into that important conversation. Thank you so much for your attention, and I look forward to the discussion following our next presentation. Thank you.
Thanks, Jen, for that input. I think it sets a great platform for my presentation too. And as Jen ended with issues around severe mental health conditions, I'm going to spend a fair amount of time on this group. Okay, but before I start, I want to wish you all a very good International Mental Health Month. I hope that you all know that October is, in fact, International Mental Health Month. And yesterday, in fact, the 10th of October was International Mental Health Day. And there have been some really interesting activities to promote awareness around mental health over the last few days. The minister was in Newcastle yesterday. The Director General of the WHO was involved in activities in the WHO. So there really does seem to be an increasing awareness of the importance of mental health. And the theme for this year, I think, is also particularly important, which is mental health is a universal human right. And this theme means many things, especially given that there is abuse and stigmatization against people with mental health conditions, and there's a lack of services. Data from South Africa suggests that about 90% of people needing care, in fact, don't get care, or certainly don't get quality care. But in the context of this talk today, this theme for me means that every person deserves, needs, and seeks mental health care should at least get it. And that persons with mental health conditions should be treated equally and with justice. Now, perhaps I should have said rather with equity rather than equally, but I didn't say equality. So probably equity, as described by Jen, is really what I'm talking about, and that there should be justice for everybody, including people with a mental health condition. And I would say that at the moment, this is not the case. And unless we address issues around knowledge and discrimination, we will not progress towards mental health as a human right. So there's actually been a lot of research in the last 20 years and more. And I have to say that I've actually been involved in research in this area for 20 years too. I was involved in research 20 years ago. And in, for example, establishing the extent of mental health problems amongst people living with HIV. So a lot of research has been done and a lot has been said about this interrelationship between mental health. And also, as Jen has pointed out, poor mental health is a risk factor for HIV. And living with HIV is a significant risk for developing a mental health condition. So it works both ways. If you have a mental health problem, you're at risk for HIV. If you've got HIV, you're at risk for a mental health problem. So mental health problems are associated with HIV risk behaviors, delayed HIV diagnosis, late ART initiation, and suboptimal HIV treatment outcomes. People who have mental health conditions very often are poor adherers to ART and less supported by programs. There's a lack of viral suppression, and there's in fact increased AIDS-related mortality. Perhaps I should just pause at this point and say that people with severe mental health conditions die 10 to 20 years earlier than people without such conditions. And part of the reason for this is because of conditions such as AIDS. And then, of course, stigma and discrimination contribute to the reduced mental well-being, as well as to negative treatment outcomes for HIV. So I'm not sure how many of you know this document. It's a joint WHO-UN AIDS document that came out last year called The Integration of Mental Health and HIV Interventions. And in this joint publication, it emphasizes the importance of integrating HIV prevention, testing, treatment, and care, and mental health services for people living with HIV. So what they try to do is to say, well, you can't separate out the mental and the physical. These are intertwined issues, and you have to treat them as far as possible as a single syndrome or a single condition, because they are interacting with each other in important ways. Okay, so Jen has spoken about the NSP and mental health. And I'm very happy to say that I believe that mental health is well integrated into the NSP, the HIV and TB and STI NSP. Just to give you some example, previously in the previous NSP, mental health is mentioned 12 times. In this one, it's mentioned 144 times. Now, I don't like to be reductionist and say, well, because it's mentioned lots of times, it means it's important. But in fact, when you look through it, it is very well integrated into the NSP in a comprehensive way and in an evidence-based way. And importantly, people with mental disorders are identified as a priority population. And again, Jen has spoken about what it means to be a priority population. I'm not going to dwell on this, but I'm sure most of you know what the key populations that have been identified are and what the priority populations are. And as I said, people with mental disorders are identified as a priority population. So as a priority population, people with a mental health condition need to receive special and dedicated prevention and treatment for both HIV and for mental health. But in addition to being a priority population, people in the key and in the other priority populations, such as young girls, need to receive mental health support and care. So this becomes complex because people with mental disorders or conditions are identified as a priority population, but unlike any other key or any other priority population, mental health is also a thread running through the services needed for all key and other priority populations. I hope that this is clear. So we need to provide mental health care and support to people in each of the key population groups, as people in all of these groups are more vulnerable to poor mental health. So basically, we have high levels of mental health conditions in South Africa. In the general population, round about 15 to 16%. People living with HIV have higher levels of mental health conditions than the general population. One study that I was involved in, it was about 43%. And then you have people who are in the key populations who in turn have even higher levels of mental health problems than people living with HIV. And then there is a triple stigma that goes along with that, because you have somebody with stigma because of HIV, stigma because they are in a key population, and stigma because they have a mental health condition. And we have a large number of people who then fit into the category of all three of these and therefore experience this triple stigma. Now, I'm going to now focus on persons with severe mental health conditions and try to talk about why this group are particularly important and why we argue that this group should become a further key population. Okay, and if they do, we think that that will change the status and the level of service that this group with severe mental health conditions will actually get. So persons with what we classify as a severe mental health condition constitute about 1.5% of the whole population. So that's a fairly small proportion of all people with mental health conditions, as I was saying, about 15 to 16% of the population. But in terms of the theme for World Mental Health Month that I was talking about, it says every person needs, deserves, and wants mental health care should receive it, and that persons with mental health conditions should be treated with equity and justice. So while any mental health condition puts people at greater risk for HIV, people with severe mental health conditions are especially vulnerable to HIV and to spreading HIV. So they're vulnerable both to getting HIV and to spreading HIV. And I'll say a little bit why. When we compare people with severe mental health conditions with the already identified key population groups, there is not equality, not equity, and not justice for this group. And I'll show you why. But first, let me ask the question, would becoming a key population make a difference? And I would argue that being a key population is in fact material. Because as much as priority populations are highlighted globally and nationally, and as much as mental health is seen as critical for key populations, and that services should be prioritized for them, key populations are undoubtedly identified for more intensive, more dedicated, and specific and highly committed interventions, including in our NSP, over and above the priority populations. I was actually at a workshop today talking about programs for key populations, and they were talking about specific centers of excellence being set up for key populations. And that for me was a really good example of the difference between a key population and a priority population, and why, if you deserve to be a key population, it will make a difference to be classified as such. So the position of a person with a severe mental health condition is so unique and is so intimately linked to HIV that we argue that they should be included as a key population. Now, why it's important that they do get such classification is because they do need special interventions from both the prevention and a treatment point of view. And if any population meets the criteria and so deserves to be a key population, then surely they should be included. And if they're not, it appears to be discrimination. And is this the AIDS community discriminating against a group of people who deserve to be in the key population group and are being discriminated against, which clearly would run against the principles that drive HIV programs and undermine principles of equity and justice. So do people with severe mental health conditions meet the key population criteria? Which conditions are we actually talking about? We're talking about conditions such as schizophrenia, schizoaffective disorder, other psychotic disorders, bipolar disorder, and major depressive disorder with psychotic features. So it's basically those conditions in which people have psychotic features. So we're not talking about general depression or anxiety disorders or PTSD or even substance abuse disorders, unless perhaps they are also people with substance abuse disorder and psychosis. Just to give you an idea who we're talking about. And as I said, they constitute about 1.5% of the population. So amongst the many reasons to focus on this group as a key population, there are three that stand out. Firstly, persons with severe mental health conditions are significantly more likely than the general population to be exposed to risk factors for HIV and, due to behavioral practices, to transmit the virus. And then in actual numbers, they not only meet the criteria for inclusion, but place a greater risk for the spread of HIV than certain groups that are already identified as key populations. So due to their mental health status, they also receive less HIV prevention and treatment. Just perhaps as another little aside, people with severe mental health conditions get almost twice as many consultations as the general population, but they receive far less screening, treatment, other interventions for physical health problems. In other words, they get seen as people who have a mental problem, and only their mental health condition is seen as worthy of intervention, and their physical health just gets completely neglected. And so they don't get screened for HIV, they don't get identified, and they die early. This is discrimination. And then thirdly, persons with severe mental health conditions need highly targeted prevention, treatment, and care programs. You can't just do for them what you do for everybody else, for the general population. And this, again, is so important for why they should be a key population, because if they are a key population, then they will get those kind of highly targeted prevention, treatment, and care programs. And they won't get that if they are not part of these key populations. And the consequences for them are probably greater risk of mortality. The other issue is that it would be nice if we could include all persons with any mental health condition as a key population. That argument does have some merit, but it's difficult to establish HIV prevalence in this group, and also to assess whether the HIV precedes or is a consequence of the mental health condition. Okay, so is the person depressed prior to or after the diagnosis of HIV? So determining the prevalence of HIV in the population of people with severe mental health conditions, we determined who they are, is a much simpler task. And these people also have very unique needs that are different from people with other more common mental health conditions. So let's look at the risk amongst people with severe mental health conditions. Well, firstly, this group tend to engage in behaviors that increase their risk of infection. including higher levels of unprotected sex with multiple partners, sex work, and intravenous drug use. So you can see that there is overlap with many of the other key populations, but then there is also quite a lot of overlap between the current key population groups. People in this category also tend to engage in hypersexuality during acute phases of their condition. When they are in an acute psychotic phase, then they tend to be more hypersexual. As I was saying earlier, they have co-occurring substance abuse problems that lead to sexual risks. They lived in shared accommodation very often and in institutions, often same-gender institutions, where sexual activity is often not accepted and protection is not provided. So if you don't accept that people are engaging in sexual activity in the institution, especially same-sex interactions, then you're not going to provide programs and protection. Next, mental health conditions are also associated with lower adherence to HIV treatment. So because of all of these things, it puts people with severe mental health conditions at greater risk. Now, if a group is going to be included as a key population, they've got to be social barriers and legal barriers. And what we argue is that people in this category are affected by both social and legal barriers that are the requirement for inclusion as a key population. People with severe mental health conditions experience poor physical health care. That's a social barrier. They experience perceptions that people with mental health conditions are unable to comprehend sex education, and so they are not given it. There are beliefs that people with severe mental health conditions are poor adherers to medication, and that's not worth providing treatment to. There's stigmatization and discrimination based on their mental health status. There's violence and abuse, including sexual abuse. So these are all social barriers. Legal barriers include people are sometimes committed to institutions without their consent, and hence they are put into conditions where they are at greater risk for HIV. And then laws in South Africa restrict persons of unsound mind. Basically, in South Africa, we found 6 studies, 3 inpatient and 3 community studies, where they looked at the percentage of people with severe mental health conditions who were also HIV positive. So
Sorry,
one
Prof,
found
sorry
20.
to interrupt you, Prof. Can you please just share your screen?
Am I not sharing my screen? Oh dear.
Not yet.
That's polite. Are you seeing it now?
Yes, perfect. Thank you, Prof.
Okay, let me just get to slide view again. Okay, my apologies again. So I was saying that there have been 6 studies, or we found 6 studies, 3 inpatient and 3 community, of the extent of HIV amongst people with existing severe mental health conditions. Okay. And what we then did is we extrapolated from these 6 studies and said, let's estimate conservatively and say that it's 23% of of people with severe mental health conditions that are living with HIV. And let's then compare that to the existing key populations. So we looked at the estimated percentage living with HIV in each of the existing categories, as well as people with severe mental health conditions. We looked at the estimated proportion of the adult population, 15 plus, the estimated proportion who fit into that category, and then looked at the estimated number of people in the general population based on this, and then the estimated number living with HIV. And you can then see that people with severe mental health conditions were higher than 2 of the 5 existing key populations in terms of the estimated percentage, and higher than 3 in terms of actual numbers. So we are saying if, for example, sex workers are included, and we're talking about 108,000 people, and if people who inject drugs are 16,000 and prison population 25,000, the estimated number of people living with HIV, but people with severe mental health conditions, is 148,000. Why should they not be included? Because they also meet those other criteria of social barriers and legal barriers. We can't understand it. So if they were included, then they would be included for targeted HIV prevention programs such as PrEP. I'm going to rush through a bit now because I would like to have some discussion time. There would be primary prevention efforts such as correct condom use would be taught, and these skills can be taught, and if repeated, can be maintained. PEP can also be important for this group, and custom key population prevention such as education programs designed specifically for this group are required to curtail HIV prevention. But if you do specifically design, then it is easy to administer, it's feasible, and it's inexpensive. And there has been research done on this. And there should then be routine HIV testing for people with severe mental health conditions. At the moment, it's very low, but essential. Okay, let me rush. And then in terms of care, HIV positive individuals with severe mental health conditions have been found to be prescribed antiretroviral therapy less often than their non-serious mental health condition counterparts. It may be because of the belief that should a person with a mental health condition be found to be positive, that they would not have the capacity to take or to adhere to their medication regularly. But research shows that that's not true, that people with mental health conditions receiving quality HIV care and specific dedicated targeted care and receive this additional support can achieve high adherence rates comparable to that without mental health conditions. So some of the care recommendations is that we do develop guidelines to support prevention, screening, and management. There were some treatment guidelines from 2013, but these are already out of date. There's got to be training of mental health care practitioners to test and treat for HIV in persons with severe mental health conditions. It should be a non-issue. They should just test because they will find so many. And then they should be providing special support programs for these practitioners, for family members, and for people with lived experience, so that they all become partners in this program. And similarly, including mental health in the training of practitioners, providing HIV services, such as nurses providing NIMART, it needs to be increased. So it needs to work from both ways. So the whole area of mental health and HIV needs far greater attention in South Africa. Though the early studies showed this irrevocable interrelationship, 20 years ago, not much has happened in terms of prevention or service development. Making persons with mental health conditions a priority population in the NSP and integrating mental health into HIV and TB care should go a long way towards improving the situation. Similarly, the emphasis of integrating mental health and physical health care in the mental health policy framework should assist. But there's thus far been very little emphasis on people with the severe mental health conditions. And I hope that I've shown why this group is so important to focus on, and also why, if there was no discrimination against them, they should be included as a key population. And if this happened, this would surely shift the attention on them and the resources dedicated to them. And this would be equity and justice as demanded in this Mental Health Month. I thank you.